Hello, good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world, and welcome to the ACNS webinars. The speaker for the first section of today is our honorable guest from Israel, Dr. Moshe Atiyah. Dr. Atiyah is a board-certified neurosurgeon and the director of skull-based surgery service in the Department of Neurosurgery at the Sheba Medical Center in Tel Hasuma, Israel. His specialty focuses on skull-based and cerebrovascular surgery. Previously, Dr. Atiyah was an attending neurosurgeon at Hadassah and Rambam, where he was operated upon in multiple skull-based surgeries. As an attending neurosurgeon, his surgical expertise focused upon keeping of intracranial aneurysms, resection of skull-based tumors, cerebrovascular revascularizations, and resection of benign malignant brain tumors, head trauma surgeries, and general neurosurgeries. He's a noted author with several publications in various peer-reviewed journals. We're extremely honored to have him today at our webinars, and he will be talking about Retractor-less surgery for skull-based meningiomas. The speaker for the second session of today is our honorable guest from China, Professor Zhang Yulin. Dr. Yulin Zhang is a neurosurgeon and assistant researcher at China-Japan Friendship Hospital. Dr. Zhang graduated from Peking University and stayed in China-Japan Friendship Hospital as a postdoctoral fellow under supervision of Professor Yang Bingyu. He is mainly engaged in the clinical and basic research of functional neurosurgery. We're extremely honored to have him today at our webinars, and today he will be talking about electrophysiological application of hemifacial spasm during microvascular decompression. The chair for this second session of today is our honorable guest from Japan, Professor Takashi Surawaya. Professor Surawaya is a professor of neurosurgery at the International University for Health and Welfare Narita Hospital. His clinical interests are focused upon skull-based surgery and craniofacial surgery. He is an important member of the Japan Neurosurgical Society. He has published several articles in the leading journals and book chapters. We are extremely thankful to him for accepting our invitation to chair both sessions. On behalf of Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers and welcome both speakers and chairs and audiences to these online platforms for our ACNS webinars. A very warm welcome to our colleagues in China, and we're extremely thankful to Professor Xu Bin for broadcasting the webinar on the WeChat channel. Dr. Atiq Ethan from Bangladesh is my co-host for today. With that introduction, I would like to hand over this online podium to our chair, Professor Takashi Surawaya.
Good morning, good evening, and good afternoon, everyone. As Dr. Ben introduced us, Professor Atiyah has extensive experience in skull-based surgery, and today's he's going to talk about Retractor-less surgery for skull-based meningiomas. I was looking forward to his lecture about skull-based surgery. Professor Atiyah, are you ready?
So thank you very much. I am very happy to be here. Thank you to the ACNS for the kind invitation. Today I will be speaking about retractorless skull-based surgery, transcranial surgery in skull-based meningiomas. And actually, this is a dynamic retraction by surgical instruments. And the goal is to achieve a limit retraction-induced brain injury because of the fixed brain retraction. Fixed brain retraction is commonly used for deep-seated skull-based tumors and vascular lesions. And this retraction use constant force to reposition the brain. And if you work for several hours, it can cause injuries. The importance of the fixed brain retraction is to achieve a very good operative line of sight, and surgical working window. This is a small synopsis of the history of the development of the fixed brain retractors, that you could see that you have here the Yashargil and Leila Bar Greenberg, the Sugita headrest, the body halo, and the tubular retractors. And the importance of these fixed brain retractors, as Yashargil said, good illumination, unobstructed vision, and a view of the whole operative field are essential value to the surgeon. The better these conditions are, the greater precision with which he can identify the structure of pathophysiological significance. But the problem is that fixed brain retraction may cause brain tissue injury. As I mentioned, especially in long operation, skull-base operation, you are very focused, you are very concentrated in the target to resect the tumor, and you apply brain retraction that may cause damage. And the damage will be by cortical mechanical damage, reduced regional perfusion causing local ischemia, and sensitivity during the operation to hypotension. If the MAP is less than 70, because of the retraction pressure, it can cause ischemia. And this mechanism, this retractor injury, can cause cerebral edema, cerebral contusions, brain contusions, cerebral ischemia, encephalomalacia, and postoperative seizures. And it's well known, and it was published, that retraction injury, symptomatic and asymptomatic, may occur in approximately 10% of skull-base tumor operations and 5% of aneurysm operations. So to avoid these complications, alternative approaches were developed, namely the endoscopic endonasal surgery, that we work below the brain without any retraction, and the transcranial retractorless microsurgery. Here you can see a nice cartoon that shows the endoscope using the natural corridor of the paranasal sinuses, working below the brain. You can reach midline lesions in the anterior skull base, sella turcica, clivus, and it's very elegant. This is an intraoperative photograph that was taken from within the sphenoid sinus, and you can see how beautifully you can see with the endoscope and reach very nicely tumors and lesions under the brain. You can see here the planum sphenoidale. You see the medial wall of the optic canal, the tuberculum sella, the sella turcica, the ICA, the lateral opticocarotid recess, the clivus, the paraclivi ICA. And it's very elegant to resect tumor. I would say select cases to take out with this technique. This is an intraoperative photograph after taking out the tuberculum sella meningioma. You can see very nicely the chiasm, the optic nerve going to the optic canal. You actually can decompress the optic canal from within the sphenoid sinus, taking out the medial wall. And then you should reconstruct the skull base to prevent CSF leak. So meningiomas are 30% of primary CNS tumors, and among them, 50% will be skull-base meningiomas. The terminology for skull-base meningioma is the origin of the tumor, namely the insertion of the tumor. you can see that the risk factors that are well known is genetic factors like NF2, ionizing radiation, theory of head trauma, hormonal factors, breast cancer. We know that patients with breast cancer have more incidence or higher incidence to develop a meningioma than the general population. And in the recent years, we know that most of the time meningioma is a benign tumor, but in the recent years, there is growing and climbing of the WHO grade 2. If we say that in 2000, it was 4 to 7% of the general meningiomas, nowadays it can reach even 30%. In account of the grade 1 meningioma, that it's less, and the grade 3 is still stable around 1 to 3%. So the intracranial locations are basically wherever there is arachnoid and dura, and you see that the skull base origin is really 50%. And the clinical presentation would be according to the tumor's location and growing rate. And this is a cartoon. You see the picture, the insertion of the skull base meningiomas. And the diagnosis is made by CT and MRI with these radiological features and confirmed by the histology and pathology report. These are some examples that show the wide dural base that is essential to make the diagnosis of meningioma. Here you see all the anterior skull base. Here you see the insertion from the tentorium. And here you see the homogeneous enhancement and the calcifications. And another common feature, radiological feature, is the dural tail in this foramen magnum meningioma. Here you can see the hyperostosis that usually has in a sphenoid wind meningioma. You see here the calcification and the hyperostosis in the planum sphenoidale. And another feature, a unique feature, is the pneumosinus dilatans. You see the sphenoid sinus is very large, and whenever you see pneumosinus dilatans, look for a meningioma. So now, if you look into it, we have to speak about the great imitators of meningiomas. This patient was admitted to our service, and the working diagnosis was orbital roof meningioma. But the patient has uveitis history, and this tumor grew very fast. So we looked at the diffusion and the ADC map, and you can see that it is restricted. And one can tell that some of the meningiomas has restriction on imaging, but we thought about CNS lymphoma. So we did MR perfusion, and you can see that there is no perfusion for this tumor, and meningioma is really high vascularized tumor, so it's not meningioma. So we did a stereotactic biopsy, and the pathology report returned back as B-cell lymphoma, and the neuro-oncologist took care of this patient. It's not a surgical disease. Another great imitator, this case I have operated upon as working diagnosis as Falk's parasagittal meningioma. At the surgery, it looks like meningioma, but at the end, the pathology report returned back as solitary fibrous tumor. Another case, this lady was having a history of breast cancer 5 years ago, and she was cured, and she was diagnosed with this tumor. And as I said, we know that a CA of breast patient have more higher incidence to develop meningioma. The working diagnosis was sphenoorbital meningioma. You see the hyperostosis, you see the penetration to the orbit, and extracranially, and at the end of the day, it returns a CA of breast. So we have also the dual-based metastasis that can mimic meningioma. The treatment, the first line is surgery. Sometimes there is small or large residual tumor that we need to radiate with stereotactic radiosurgery, fractionated stereotactic radiotherapy. Sometimes SRS or FSR by themselves. The very good example for it, if you need to treat, for example, cavernous sinus meningioma, probably is the best treatment today to give the patient. And one of the most common treatment in meningioma is careful observation. I follow plenty of patients with small meningiomas, asymptomatic, without cerebral edema. We can follow the patient. Sometimes it doesn't grow because of fibrosis, calcifications, but we have to watch carefully because it can grow later on. So the clinical factors affecting the treatment of choice is, of course, patient's age, tumor size, neurological status, cerebral edema, patient's comorbidity, and can I achieve complete resection? The basic transcranial skull-base approach are listed here. This is a patient that I operated via the bicoronal subfrontal approach. Usually, I tackle this tumor via the pterional approach, but in this case, you can see that the tumor is violating and penetrating the ethmoid sinus. So in order to take it all, I need to reconstruct the skull base. So for me, the most important thing in reconstruction is vascularized flap. If you go from above, this is the pericranial nasovascular flap. If you go for below, this is the nasoseptal vascular flap. So because of this, I took it subfrontally. Olfactory groove meningioma, pterional approach, my favorite approach. Enteroclinoidal meningioma, pterional approach. This is a middle fossa floor meningioma that you can see a large cerebral edema that can be caused by 3 mechanisms in meningiomas. One, it can be penetrating the PR or the brain, like atypical meningioma. It can disturb the venous outflow and cause this edema. And it can be WHO grade 1 secretory meningioma that it's very typical to cause really large, inappropriate cerebral edema in these cases. So I operate on these patients via the subtemporal approach. You can see on the right the postoperative imaging, and on the left, the 3 weeks postoperative image. And you can see that the cerebral edema almost resolved completely after only 3 weeks by taking out. And guess what? The pathology returns secretory meningioma. It is well known. This is an example of tentorial meningioma that goes supratentorial. In this case, I operate in the subtemporal approach. This is a CP angle meningioma. This is large CP angle meningioma. You can see in these cases, the broad band based on the petrosal bone and the tentorium. And in these cases, after draining CSF from the lateral cerebellomedullary system, I go immediately infratentorial supracerebellar to devascularize the tumor from the tentorium and detach it, then debulk it, and it will be much easier to take out the tumor from all the neurovascular structures then. This is an example of foramen magnum meningioma that I operated via the far lateral approach. And this is an example of tentorial meningioma, falcotentorial meningioma, to be correct. And in this case, I went through the occipital transtentorial approach. You can really approach it also via the infratentorial supracerebellar approach to take out this component, and the brain. We remember that the brain is pulsating and will push this component to your surgical field, but I prefer the occipital approach. So as a young neurosurgeon, after I returned back from my clinical fellowship in the US, I started to do these operations. And I was preparing the fixed retractor system every case. And at the end of the case, I saw that I'm not using fixed brain retractors from case to case. And I realized that I don't really need it. So I went to the literature and I saw this milestone paper written by Spetzler and Sanai. It was published in the GNS in 2012. And you can see that in 6 months, Dr. Spetzler operated on 223 consecutive lesions, very high flow institution at the PNI in a very short period of time. Look at the numbers: 159 vascular lesions, 64 skull-base tumors, and 37 meningiomas, among them skull-base meningioma. And they really did well. In 97% of the cases, Dr. Spetzler didn't use a self-retaining retractor system. So I got my affirmation and confirmation, and I continue with that. I use an operating microscope with mouthpiece for control. It allows you to keep your hands in the surgical field, the neuronavigation, intraoperative monitoring, whenever the brainstem and the spinal cord are involved, and choosing operative corridor according to the surgical target. The name of the game to use this technique, we have to achieve early on at the start of the intradural microsurgery brain relaxation. Otherwise, it's very hard not to use fixed retractors. And we achieve the brain relaxation by applying general anesthesia, osmotic diuresis, hyperventilation. And one of the most crucial things is the positioning. Whenever I need to position the patient, I go to the OR and position the patient by myself. It's one of the crucial steps to achieve great convenience for the microsurgery. The patient's head need to be for maximal gravity enhanced retraction, what we called the natural Newton retractor. I do not use lumbar drain. I may consider EVD in select cases. And the most important thing, I use routine microdissection to allow draining CSF from within the arachnoidal planes and the regional cistern during all the surgery, so the brain is relaxed and you can tackle the tumor and take it out without violating the brain. These are some details from my series at Sheba. Until March 2022, I have operated on more than 100 consecutive patients with skull-based meningiomas, with diversity of skull-based meningiomas. And you can see that the workhorse approach was by far the pterional approach that I really love. Those are some imaging of my patients in this series. You see these skull-based meningiomas everywhere. We have been able to reach gross total resection in 72% of the cases. And you can see here that in my series that the WHO grade 2 reached 16%. It's very high. It is well known that skull-based meningioma are considered more benign than the convexity meningioma. And you can see that WHO grade 2 is climbing, maybe because of the new criteria. And I believe there are some new things that we do not really know about the meningiomas. Here you can see that 94 patients had Glasgow Outcome Scale 5 at follow-up, and we looked into the skull-based meningioma that were involving the optic pathways, and you can see that most of the patients were improved or stable after the surgery. So some cases, you can see that in this huge tumor, this anterolateral skull-based meningioma, the pathology, the meningioma will create the corridor for you, so you do not need any retraction to tackle this tumor. Another case of olfactory groove meningioma, you see I use the pterional approach, my favorite approach, because you do not violate the frontal sinus. I reach the optic nerve and the ICA early in the surgery, and I can take the tumor out, all of it, and with not need with skull-based reconstruction and less degree of CSF leak after surgery. In these cases, the meningioma will take you down all the way without any retraction. Even in deep-seated tight Sylvian fissure, I think one should invest in this fissure. In these cases, what I'm doing, I open the dura to the skull base very shallow, and I dive subfrontally to the carotid cistern or the medial Sylvian fissure when the carotid cistern is blocked by the tumor. I open a tiny arachnoid membrane, and I sit there and drain CSF very easily and get the brain relaxed and continue with the surgery. So splitting the Sylvian fissure for this anterolateral skull-based meningioma, cellar, paracellar, cavernous sinus, splitting the fissure is crucial and very important step. We learn it from Yashargil that developed the pterional approach. You can see in these cases, this is left side, you can reach everywhere. The olfactory groove, planum sphenoidale, tuberculum sella, sella turcica, optic nerve, supraclinoid ICA, oculomotor nerve, always medial to the anterior petroclinoid ligament. The A1, M1, medial and lateral lenticular stripe beautifully reach this area. The pterional incision you see and craniotomy, the subfrontal incision and craniotomy. You see the dicoronal approach with the pericranial vascularized flap. You see the eyebrow incision to use the frontal approach, better for posterior tumor, not to the anterior tumor. This is cadaveric dissection. You see the zygoma. Once you want to extend the pterional approach to do orbitozygomatic osteotomy, you see the route to the inferior orbital fissure, the McCarthy keyhole, the frontal dura in the McCarthy keyhole, the periorbit, the frontal zygomatic suture. And here you see the frontal and temporal dura, the periorbit. And this is very important. When we use the pterional approach, I really do it like skull-base approach. You see here the meningo-orbital band, the superior orbital fissure. So you have to reach, this is right side, the meningo-orbital band. And if you unlock inferiorly and drill it, you can reach the lateral wall of the cavernous sinus. And if you unlock superiorly and posteriorly, you reach the anterior clinoid process. You see, you have the temporal tip here, and it's very nice approach to reach skull-base tumors. And this neurosurgeon, Dr. Vinko Dolens, he taught us how to reach the cavernous sinus extradurally. That is very important nowadays. And here you see the anatomy after extradural clinoidectomy. And here you see the lateral wall of the cavernous sinus, the inner layer. And this is Professor Felix Umansky, one of my mentors, that taught us a lot about the cavernous sinus. And here I opened in the cadaver dissection the Parkinson triangle. And I want you to remember that the abducens is always medially to V1, always medially to V1. And here it's a nice picture to show how important is to drill and to do the pterional approach correctly. Here you see the frontotemporal craniotomy. You see the dura, open the dura. You see the Sylvian fissure is very short here. And look here. After drilling the greater wing of the sphenoid, the lesser wing, the lateral wall, and the orbital roof in the posterolateral portion, look it up. You can see the temporal tip here. You sit on the subfrontal area, and you bring the skull-base meningioma to be like convexity meningioma. Look here. Look at the Sylvian fissure, the subfrontal area. The temporal tip is much more better than the picture on the left side. So opening the Sylvian fissure, you can see the lateral sulcus. This is a model that you can see. You can see here the medial Sylvian fissure that we can open it during doing subfrontal approach. It's very important. Here you can see that you can reach all the anterior skull-base area. Same as eyebrow incision, you can see that you can open the medial Sylvian fissure for brain relaxation. It's very important. And this is a different kind of Sylvian fissures. Sometimes it's very easy. Sometimes it's the normal one. And sometimes it's very tight with cerebral edema. So by splitting the fissure, this is a nice fissure, very easy to dissect. We drain CSF from within the fissure, get brain relaxation, and separate the frontal lobe from the temporal lobe to allow positioning gravity retraction, access to the anterior fossa, cellular paracellular area, optico-carotid triangle, colomotor triangle, and of course, early identification of the optic nerve and the ICA. Some examples of splitting the fissure. It's very crucial to use this technique. Left side, we split the fissure distal to proximal using the beaver. Using the technique of spreading dissection with the microbayonet, you see the suction. Following the scissors, the suction is like a dynamic retractor. Follow with sharp dissection along the tumor capsule, a little bit stretching the arachnoid to make sure that you are not violating any blood vessels. Continue with spreading dissection. See the suction is a dissector, is a retractor, peeling the arachnoid. Then you can see the MCA and you can tackle this tumor. This is another example of cavernous sinus chondrosarcoma. In these cases, whenever I need to reach the posterior part of the cavernous sinus, I split the fissure extensively, as you see here, left side, using the suction and reaching the cavernous sinus, opening the wall and taking out the tumor. This is another case of small anteroclinoid meningioma, riding of the optic nerve. Same technique, left side, the suction will stretch the arachnoid and the micro scissors will cut the arachnoid without violation of the blood vessels. The suction help you to retract, and then you will sit on the tumor and take it out. You see, I use a lot the cotonoid, the paddy, to protect the brain and to keep it in his position, kind of passive retraction. It's very good. This is an example of ossified tuberculum sella meningioma, that the fissure was hard and adhesive. So I went to the proximal fissure, very shallow, and you see you open the arachnoid and sit there and suck the CSF and drain it, and easy, step by step, the brain is more lax and you can tackle the tumor subfrontally and take it out. You will see, continue to open. It's very adhesive in this case. See the MCA, one of the branches, the dissector elevating the arachnoid. The suction is following and stretching the arachnoid. You see the oculomotor nerve, always medial to the anterior petroclinoid ligament. You see the carotid, the optic nerve there, and the tumor. Now I can resect the tumor. You see the contralateral optic nerve. See the tumor, taking out this tumor, the optic nerve. You see the pedis, and this is the result. Actually, the pedis and the cotonoids are holding the brain from pulsating to close your surgical window, and also, of course, protecting the brain. I would recommend to use pedis, especially in the giant and the large tumors, because the cotonoid will keep the arachnoid plane for you, and you can return back and go and extend your dissection. The working windows through the pterional approach, you see the oculomotor triangle, you see the oculomotor, right side carotid, optico-carotid triangle. and the interoptic spaces. You see the pituitary stalk, optic nerve, ophthalmic, and superior hypophyseal. And you open the Lilliquist membrane, you have the basilar artery there. And you recognize this giant neurosurgeon. This is Dr. Osama El-Mefdi, that taught us how to resect meningioma using the 4Ds of El-Mefdi: devascularize, detach, debulk, and then dissect. It's very important. This is an example of anterior clinoid meningioma, splitting the fissure, left side, doing dissection along the capsule of the tumor. You see the suction is kind of dynamic retractor. You see the spreading dissection. You see the CSF whenever we pull the tumor that blocked the CSF, debulking. You see the pedis again, protecting the brain and keeping the brain in its position not to close the surgical window. Here, dissection from the optic nerve that was pushed downward by the tumor. You see a little bit stretching. I can cut the arachnoid and separate it from the optic nerve and take out all the tumor in this case. This is another case of planum meningioma, narrow window working below the brain, subfrontally, debulk, making more room. You see the optic chiasm, the bilateral optic nerves, unroofing the optic canal on the right, and taking out the tumor from the medial portion of the optic canal. You see again, the pedis are protecting the brain and keep window. If there is not cerebral edema, it takes time. So this is the retrosigmoid approach. I usually do the true lateral positioning, the incision, the curvilinear incision. You see here the bony exposure and this craniotomy. I try to do inferior cut to reach early on the lateral cerebellum medullary cistern, open it, drain CSF, and then continue the durotomy. After I have follow it, I have this final exposure. This is an example, opening the cistern, drain CSF, and now continue the durotomy. The cerebellum is much more lax, and you continue the surgery. You see the CSF is coming without a fixed retractor. What importance in this giant tumor, I look every time at the cisterna magna, and I see if it's not blocked. In this case, it's not blocked, so I know that I can deal with that. I open the lateral cerebellum medullary cistern, drain CSF, and take the tumor out. This is an example of CP angle meningioma. Right side, you see the 7-8 complex, dissection from the tumor, bulking of the tumor, no retractors. You see the 7-8 goes to the IAC, no retraction. A small piece of tumor that was adhesive to the brainstem and the lower cranial nerves. I used the pedi to protect the brainstem. You see the suction is like dissector, and the scissors are like dissectors and taking out the tumor. In this case, look at the cisterna magna. It's blocked. and there is obstructive hydrocephalus. So at the start of surgery, I inserted an EVD, drained CSF, and it makes all the difference. And it was much easier to resect this tumor with this temporary CSF diversion. So the quiet revolution turned to be the loud revolution. I used only in one case that you see here, this medial CP angle meningioma, that part of it was medial to the fifth nerve and part of it lateral to the fifth nerve. I use EVD in 2 patients with giant CP angle meningioma. I didn't use lumbar drain. There was no exacerbation of cerebral edema. 2 patients had small postoperative contusions, less than 2 centimeters without clinical significance. And there was no newly diagnosed postoperative seizures. To conclude, retractorless microsurgery is very practical and doable. Fixed retraction can be replaced by dynamic retraction. With surgical instruments, limit the risk of retractor-induced brain injury. So this is my giant teachers and mentors, Lali Gamshekar, Sergei Spector, Sepi Hanjani, Fadi Sharbel, Moshe Hadani, Gil Sviri, Igal Shushan, Menashe Zaharu, Felix Umansky, and Ted Schwartz. I'm really grateful. I was lucky. I had great teachers, and I learned from them a lot. But you have to remember that we are very creative human beings and neurosurgeons, and at last you will do your way. Thank you very much.
Thank you very much for your showing the great result and clear anatomy and very insightful, highly technical, informative lecture. And you mean the brain to do the retractor-less surgery, the brain relaxation is important, right? And to get the brain relaxation, using the gravity retraction is important. That means positioning is very important, right?
I agree.
Yeah. And anyone, some question?
Yeah, there is one question in the chat box by Dr. Harshit Parekh. Do you recommend drilling of anticlinoid process extradurally or intradurally?
So first and foremost, I think one should see very meticulously the pre-operative imaging, the MRI, the CT scan, to look carefully if the anterior clinoid process is hyperostotic, to see if the anterior clinoid process is pneumotized, usually extension of the sphenoid sinus. And then if you realize that you need to drill it, you need to take it out, generally speaking, I would say if this is a tumor, I will take it extradurally. You have the dura that is the best natural protector to the brain. And if it's aneurysm, like ophthalmic aneurysm that you should clip, I think it's better off to do the clinoidectomy intradurally. But let me tell you something. You can manage this kind of tumors without drilling the clinoid. You should tailor the specific approach for the specific patients. If there is no tumor inside the anterior clinoid, there is no hyperostosis, and the enteroclinoid is pneumatized, I would not touch it.
Yes, thank you, Professor Etienne, and thank you very much for your message. And I'm a neurosurgeon from Hong Kong, and I'm also had a particular interest in skull-based neurosurgery. So I agree with what you said that most of the surgery we don't need retractors, and the key to this, as you mentioned, one is using the patient positioning, and one is I think important is the bony work, the bone work during tailored to the patients is an important key to avoid the retractors. And also the release of the CSF from the system, very important steps. And I also found that to protect the brain, the dural exposure tailored to the patient is also important. We don't need too much dural exposure. The dural opening, the dural can protect the brain. And but sometimes one tricks that I sometimes use is to attach the stitches to the dura to hold it with say an artery or scissors to provide minimal retraction during the extradural work. Sometimes these tricks might work. I do have a question for you. In your experiences, when would you think a retractor is helpful, or sometimes you cannot do without a retractor? Is there any situation that
Yeah, of course.
that
If you,
yeah.
I agree. I agree. If I told you about my series, I use only once, but of course, the goal of the surgery is not to do the surgery retractor-less. If you
Yeah.
find out that you are not managing the case, I cannot reach the tumor, sure enough, take the retractors, elevate the brain, and do it. The goal of the surgery, take out the tumor without violation of the brain for the sake of the patients, and get very good neurological results. But most of the time, if you look carefully, I excluded the petroclival meningiomas. The petroclival meningiomas are a unique group of meningiomas. Most of them, if the patient is young, you have to tackle it with the petrosectomy, with posterior petrosectomy. Usually, you have to combine it with subtemporal approach. You do not go like in acoustic retro lab. You need to retract the sigmoid sinus medially, to take up the temporal lobe, to cut the tentorium. It's a different story. In these cases, usually one should use fixed retractor. So the taking home message is that most of the skull-based meningiomas, once you have the experience and it tends to be the expertise, you do not need fixed retractors.
Thank you. Just a last comment that also with sometimes I think that with the advance of the endoscope or exoscope in the open surgeries, sometimes we can use it to have a better visualization without much brain retraction. That's why I think. Thank you so much for your lectures.
Yeah, I would like to add a comment regarding the endoscopic approach for skull-based meningiomas. I think the endoscopic approach is very nice. It's, working with below the brain, no retraction. But in meningioma, you have to remember, at the end, you have to reconstruct the skull base and to prevent CSF leak. And if you have giant olfactory groove meningioma, I would recommend do not tackle it endoscopically, because you don't have to end up with large hole in the skull base, and then 3 years afterwards, you have CSF leak. So I think one should tailor the specific approach for the specific patient. I think for midline, select cases, tuberculum sella, planum sphenoidale, small hole in the skull base, it's very elegant to do it. But if you have large tumors, it doesn't make sense. The transcranial approach, in my opinion, it's much better, less risk for CSF leak. And I showed you, you can do this surgery without brain retraction. Like an operation, an army operation. You go in silence, you walk there and return home without anyone that feel that you have been there. In our case, the brain.
Yes. Thank you. Thank you so much.
Thank you very much, Professor. Luis Barba used to tell that skull-based meningiomas is like going to a robbery. You get into the bank, open the lockers, get out with all the tumor without alarming anyone. So that is the analogy that he gave us.
Yes.
There is one more question in the chat box,
Yes.
which is from Michael, who asks, does type of Sylvian fissure has any impact on the dissection process and the post-operative complications like brain edema?
Yeah, I agree. As I told you, there are several types of Sylvian fissure. You look very meticulously at the preoperative scans. And as I said, whenever I see CSF in the Sylvian fissure, I go from distal to proximal. Very nicely, you separate it, you split it, and it works very well. Once the fissure is very tight, I open the dura very shallow, as you said, to not allow the brain to get out like mushroom outside, and I go subfrontally, very shallow, with pedis protecting the brain, and I go to the tumor, go around the capsule, and if there is the carotid cistern, I'd open it. And once you open it, it's amazing. You sit there and drain CSF, and the brain will relax. If the carotid cistern is occluded, I go lateral to the medial portion of the Sylvian fissure. You always find it. You open the arachnoid, drain CSF, and that's it. You continue from there. Okay?
Thank you very much. To add to what you have said, I would like to answer Michael that there are 4 types of cisterns as described by Professor Yasser Gill, and one of the papers that came out in 2013 by from Essen, Germany, by Hannah Angard, who the title of the paper is anatomical configuration of Sylvian cistern and its outcome on thyreonal craniotomy for clipping of aneurysms. In that paper, type 3 Sylvian, which is like narrow Sylvian with either frontal or temporal herniation, temporal lobe herniation, were associated with significant post-operative brain edema. So that one paper that Michael can read about. 2 questions from me. You showed in your series the Simpson's resection was grade 4 in 9% of your series. What sort of tumors were there where you were only able to just take a biopsy in them?
Yeah. I'm telling you that Simpson grade 1 and 2, all of you know, take the tumor out, you take the dura, you bipolar the insertion of the tumor. For me, Simpson grade 3 is, for example, I left tumor in the cavernous sinus. Most of these meningiomas that I called grade 3, Simpson grade 3, it's meningioma, clinoid meningioma, sphenoid wing meningioma that penetrate the cavernous sinus. There is no reason nowadays to enter the cavernous sinus. So I take all the tumor out, I follow the patient with grade 3, a Simpson grade 3, or give them a SRS or FSR according to the location in approximation to the optic nerve. The Simpson grade 4, it means there is a small tumor intradurally that encase blood vessels that I couldn't dissect. You know, the meningioma sometimes can narrow the blood vessel and really penetrating the adventitia. So it's very, very difficult. So for that meningioma, I would say 9% or what you say for grade 4 meningiomas.
Thank you very much. Another question from me is that we saw you judiciously using the CUSA very near to the tumors near the optic nerve. Many of us are very skeptical or afraid to use CUSA. What is the setting of the CUSA that you use when you use near the optic nerves?
Thank you. So first, I do not use the CUSA unless I see very clearly the optic nerve. Once I have the optic nerve in my hands, I see the border of the capsule. I see the optic nerve, I use the CUSA. And especially if you saw there was a case, sometimes the meningioma can be very fibrotic and very ossified. I use sometimes the shear tip for these hard cases, but I use the CUSA only when I really identified exactly where is the optic nerve. And let me tell you another thing. It's very important to debulk this tumor. Do not do dissection from the optic nerve, from the blood vessels, unless you debulk this tumor. Otherwise, you cannot mobilize the tumor capsule. And as you saw, I really use the suction to make some tension. I mobilize the capsule to stretch it, and then to cut along and very adherent to the meningioma capsule. If you do not debulk the tumor and you try to dissect it or use the bipolar, you are going to violate the optic nerve and the blood vessels. It's very important to debulk. And meningioma, in my experience, can be, we love the meningioma that I enter the suction and it's suckable and it's really nice. But most of them are very fibrotic, very calcified, and you need to debulk this tumor to do very fine dissection for the sake of the patient.
Thank you very much. We can go back to our chair, Prof. Sugawara, for his comments and final concluding remarks.
Okay, actually, I'd like to add some comments, like especially for the young neurosurgeon. There are some opinions that retractors can be useful. I mean, the fixed retractors can be useful when used well. I mean, softly, gently, but harmful when used like poorly. And so, I mean, sometimes the fixed retraction is very effective. I mean, not pushing, just holding the brain. I'd like to add some. And actually, okay. And I'd like to ask about, can you tell us how much rotation of the head position for the transthubian approach, like ICPC aneurysm or something like that?
Yeah, I tell you. For pterional approach, for me, it's different. Where is the pathology? If the pathology is in the anterior skull base, like olfactory groove meningioma, I prefer to rotate the head 45 to 50 degrees to the contralateral side, so I can reach the anterior portion from the lateral sylvian fissure. If the tumor is posteriorly, planum, tuberculum sella, anterior clinoid, okay, sphenoid wing, usually I rotate the head between 15 to 30 degrees only. Because in these cases, I want the tilt, so the frontal lobe will fall down, and I have the subfrontal approach targeting posteriorly, because I need the posterior portion of the anterior skull base. I need to be paracellar region. I need the lesser wing, the greater wing, and even the subtemporal area that we know that giant clinoid goes all around the anterior petroclinoid ligament, continue to the tentorium sometimes. So it's very important that you have the trajectory. Anterior, more rotation. Posterior, less rotation.
Yeah, I agree with you. Especially for clipping for the ICPC aneurysm. When I was young, I learned 30 or 40 degree rotation is better. But I think the 15 degrees rotation is enough, because, as you told us, the gravity retraction, the frontal lobe and the temporal lobe. So
absolutely.
most of the lobe was effectively relaxed. So 15 degrees is a very effective rotation, I think.
I agree.
Okay. Thank you very much.
Thank you.
So we can close the session, Prof. Sugara. Right. So Ben, we can move on to the second session.
So shall I invite our second speaker, Professor Zhang Yulin? Zhang Yulin is a neurosurgeon and system researcher at the China-Japan Friendship Hospital. And he graduated from the Peking University and stayed in the China Friendship Hospital as a postdoctoral fellow under supervision of Professor Yan Bingyu. And he's mainly engaged in clinical and basic research of functional neurosurgeries. His topic today will be an electrophysiologic application in hemifacial spasm during microvascular decompression. So shall I give the floor to Professor Strong, please?
Okay, can you see my screen? Hear me?
Yes.
Yes.
Okay. Hello, dear Chairman, Professor Ben, Takeshi, Moshita, all colleagues and friends in our webinar. Good night, or maybe good morning, good afternoon to all of you. I'm Zhang Yulian from China-Japan Friendship Hospital, and thanks to the invitation of ACNS Education. It's my honor to have a presentation here. This report comes from the work of Professor Yuan Bing team. Okay, let's begin with the topic, intraoperative electrophysiologic monitoring of hemifacial spasm in microvascular decompression, IOM in HFS-MAD. Hemifacial spasm is characterized as the voluntary twitching of one side of the face. It is thought to be due to the positive vascular compression of root exit entry room of the facial nerve. Microvascular decompression has been considered as the first surgical choice with most effective treatment. Although MVD has been performed for many years, it still has a certain failure rate and complication rate. So how to improve the surgical efficiency and reduce the occurrence of complications is still the direction of our efforts. Intraoperative electrophysiological monitoring, IOM, is considered an effective means to improve the surgical effectiveness and reduce the complications rate, and is widely performed intraoperatively. I'm fascinated by IOM, and I think it is the only way we can have a communication with the patient's movements or sensations while patient is under anesthesia during surgery. Electrophysiologic potentials are the language of the communication, and it's our job to figure out how to better understand and translate it. Improving effectiveness and reduce complications is the significance of IOM work. For HFS MAD, we mainly focus on the function of facial and auditory nerve monitoring. The facial nerve is mainly concerned with the effectiveness of MAD, and the commonly used method includes abnormal muscle response, also known as lateral spread response, F wave of the facial nerve, blink reflex, motor evoked potentials of the facial nerve, vascular evoked potentials, and free electromyography. The auditory nerve is primarily concerned with the complications of hearing loss. Commonly used methods include brainstem auditory evoked potentials, BAEP, electrocochleogram, eCochlear-G, auditory nerve compound action potentials, CAP, electrical auditory brainstem response, EABR, etc. Since the exact mechanism of electrophysiology is not really well understood, and even some mechanisms and hypotheses are still controversial, in-depth research is still needed. This report is based on my personal understanding and some of the work done by our team. Today, we focus on two of the most commonly used IOM in HFS MVD. They are AMR and BAP. First, the AMR. Let us first review the history of the discovery of AMR, which was clearly described by Professor Moller and Janita in 1985, 40 years ago. AMR refers the pathological response that can be recorded in other facial nerve branches by stimulating a branch of the facial nerve in patients with HFS, and is a characteristic response of HFS. This response is not present in normal individuals and is therefore called an abnormal muscle response. AMR it is of great diagnostic significance. When AMR monitoring is used intraoperatively, it helps to determine the corporate vessel, as well as to determine the sufficiency of the facial nerve decompression. And the experience of the AMR during MVD often predicts a successful surgery. At the same time, because this response is related to the spread of the potentials on the branches of the facial nerve, it can also be called the lateral spread response. In practice, we often use two methods. One of which, as shown in the left finger, is to give stimulation in the mandibular marginal branch of the facial nerve. On the one hand, the potential is transmitted to the muscle innervated by mandibular marginal branch, forming the M wave. And on the other hand, it spreads backward to the central end and travel back along the original way, forming the F wave. At the same time, this potential also spreads to other branches of the facial nerve, such as the temporal and zygomatic branch, forming what we call AMR. The figure on the right shows the stimulation of the zygomatic branch and recorded AMR in the chin muscle. In normal subjects or patients cured by MVD, AMR and F waves cannot be evoked or elicited. However, in patients with HFS, the successful rate and stability of F wave is much lower than that of the AMR, so eventually AMR is widely used for IOM. There are also places where there are two types of monitoring combined, or to monitor other muscles innervated by the facial nerve, such as the frontalis and the platysma. For an ideal indicator to guide surgical monitoring, we wish the AMR corresponds to the efficiency or adequacy of decompression. In other words, if the AMR is present, the patient is still spasm, there is still compression, decompression needs to be continued, and surgery cannot be stopped. And if AMR disappears, the patient is cured, suggesting that the decompression is sufficient and the surgery can be ended. But in the reality, this is not the case, and AMR and clinical outcome do not seem to be correspond. For example, some patients are unable to elicit AMR, partly related to the use of anesthetic muscle relaxants. Secondly, after release of the CSF, AMR may disappear in some patients, which may be related to the diminished compression of the REZ after CSF release. Again, after decompression, the response sometimes do not disappear immediately, but only at the time of skin suturing. Also, sometimes the AMR does not disappear and changed from beginning to the end. Also, as far as the postoperative outcomes are concerned, patients in whom AMR disappear may still have spasm, but patients with AMR present may be cured or experience a delayed cure over time. This variability of AMR and the mismatch with the symptoms makes the electrophysiologists and surgeons often question the reliability of AMR, thus to some extent limiting its use in IOM. Therefore, how can we better understand and recognize these states of AMR and be able to help our clinical practice? To explore this question, we reviewed the previous papers. We first focus on the right half of the section on whether AMR and clinical outcome were consistent, and many papers document this inconsistency. We see that of the 555 patients whose AMR disappeared, 44 patients, about 8% still have symptoms, suggesting a false negative AMR. In contrast, of the 141 patients with positive AMR, 101 patients, or about 72%, have symptoms that disappeared, reflecting a false positive of AMR. In other words, when the presence of AMR during MVD, the probability of predicting that the patient's symptoms will remain is less than 30%. Whereas more than 90% of patients will be cured if AMR disappears. This suggests that its positive predictive value PPV is low, and while its negative predictive value NPV is high. So it seems that the AMR wave is elusive. So what might be the cause of this phenomenon? To answer this question, we must first look at it from the perspective of an electrophysiologist's view. In other words, how is the disappearance of AMR determined during surgery? This is seemingly a simple question, but in fact, it involves the parameterization of the electrophysiology physiology instrument. Let's see the left part, which is the parameter setting for IOM, which in terms of the stimulation current that makes the most difference, while each article describes the current intensity used to elicit AMR, the range of this current intensity is not standardized. Some use up to 10 milliampere, while some use 20 to 30, and others use 50 or even 100 milliampere. On the other hand, returning to the clinical perspective, how we evaluate the clinical outcome of HFS. First is the judgment of the cure, not cure, and the delayed cure. The time when we evaluate the outcome is not the same. Some go by immediate post-operative symptoms. Some does it when the patient discharged, while others make an evaluation by the last follow-up visit. Both electrophysiological parameter settings and clinical judgment have a huge impact on the judgment of the AMR reliability. so it is inappropriate to discuss the predictive value of AMR in isolation from these two factors. Another important question is AMR really a dichotomous indicator? This is the monitor result from a patient with HFS. On the left part of the picture, at the beginning of the MVD, we build the baseline. We test the AMR at 10 milliampere intervals from the 10 to 100 milliampere. And we can see that the AMR is getting more pronounced as the current is augmented. When the MVD was over, we tested again in the same way, but notice, by this time, if a stimulus above 50 milliampere is used, the AMR is still present, and the AMR is absent below 50 milliampere. If we use the dichotomous perspective, then for this patient, is his AMR considered present or absent? In other words, under the same monitoring method, the different stimulation threshold cause the different interpretations. Therefore, to investigate this issue, we have modified the traditional monitoring program. Traditional monitoring involves at the different time points of the surgery using one or several threshold or supra-threshold stimuli to observe the presence or absence of AMR. The stimulation intensity is often below 30 milliampere as reported. Our team used the threshold tracking method of AMR, which in a quantitative way to monitor the illicit threshold of AMR throughout the procedure at a range between 1 to 100 milliampere to find the minimal threshold that can elicit the AMR and plot. As shown in the right part, the vertical coordinate is the minimum threshold that we can elicit AMR. The horizontal coordinate is the surgical process with the nose of the baseline after anesthesia, skinning, release of the CSF, arachnoid dissecting, decompression, skin closure, and the end of the surgery. A detailed graph of AMR threshold changes can be formed for each patient. We enrolled a total of 72 patients in this study. This is their general information. For anesthesia, only minimal suscoline was used, and anesthesia was maintained with intravenous anesthetic and without administration of a muscle relaxant until the end of surgery. This ensures a stable AMR prior to skin incision. It should be noted that one of the side effects of suscoline is malignant hyperthermia. So it is important to communicate with the anesthesiologist team in advance and to have the antagonist drug, dantrolene, and to have a plan dealing with this. This is the mourning method and evaluation of clinical outcome. AMRs were recorded from the orbicularis oculi muscle after stimulation of the marginal mandibular branch. The stimulating current was a single square wave pulse with a duration of 0.2 millisecond. The bandpass was 5 to 3 kilometer hertz. The monitoring had the stimulus intensity ranging from 1 to 100 milliampere, which is the same as the widest range that have ever been reported and proven to be safe. The clinical outcomes of the patient were classified into following three groups: immediate cure, delayed cure, and no cure. Immediate cure refers to the patients whose spasm never occurred after surgery. For academic purpose, we use the most restrictive criteria for the definition of delayed cure. This refers to the patients whose spasm exists for a period of time after surgery, regardless of how long, and then the spasm completely disappeared. This delayed period may be hours, days, weeks, months, or years. And no cure referred to the patients whose spasm was persist. All the patients was followed up to 2 years. This is a graph of the threshold curves of 72 patients and based their change. we characterize them into 5 types. Pattern A, accounting for 33% of the patients after MVD, the threshold of the AMR can be stabilized above 100 milliampere, which means that the AMR can no longer be elicited until the end of the surgery and rarely fluctuated after decompression. This is a stable type of AMR change. Pattern B, in 50.6% of the cases, the threshold reached over 100 milliampere at one point. However, during the subsequent procedure, the threshold dropped again and eventually stayed at the different threshold level. The pattern C, in 22.8% of cases, the threshold was never raised above 100 milliampere, and in subsequent surgical procedures, the threshold fluctuated and eventually stayed at different threshold levels. Pattern D, accounting for 90.3%, their threshold never exceeded more than 30 milliampere, but the amplitude of their AMR was significantly reduced and eventually dropped below 50% compared to the baseline. These 3 patterns of the patients just mentioned, B, C, D, all belong to the unstable type of AMR threshold change. Finally, pattern E, 5 patients accounting for 8% of the cases, the threshold and the wave amplitudes remained nearly unchanged during MVD, which is also a stable AMR. We can see that the pattern A and pattern E are stable, and stable presence or stable disappearance, while BCD is an unstable state of the threshold. Let's look at the outcome based on the 5 AMR patterns. Any pattern, we can see that any pattern A or A to E is likely to be cured post-MVD, just with different possibilities. Second, the patients with stable threshold over 100 milliampere have a very high rate of immediate cure, with only a very small number of patients experience a brief period of delayed cure for a few hours after surgery. The patient with delayed cure almost always fall into the category of the unstable AMR change, pattern BCD, intraoperatively. And at the same time, all of the patients who did not cure were present in group E. That is, similarly, this modified quantitative method can partially correspond to the outcome of the different patients. However, if we follow the conventional perspective in a dichotomous way, using a certain threshold of stimulus intensity, for example, 30 milliampere, as a boundary to classify the AMR into the positive or negative, we can see that both the AMR negative and positive group, they both have a large number of patients with delayed cure. In this group of patients, post-surgical symptoms are still present, some of which disappear very quickly, while others take many months or even a year or more to cure. The large number of the patients in this unstable state creates a lot of confusion for the surgeon, especially for the inexperienced surgeon. It also creates a distrust of traditional AMR monitoring, which also contributes to the opinion that AMR is not reliable in HFS MVD. However, it is important to note that for the large number of AMR threshold instability type states that occur during the surgery, especially the pattern C, both inadequate decompression and insufficient decompression may contribute to this state. Strictly speaking, in this case, we do not consider AMR to be a predictive indicator, but rather a status indicator. It may reflect the excitability of the facial nuclei. It is also more consistent with the clinical observations of the delayed cure. Therefore, based on this intraoperative change in AMR, we hypothesize that the AMR not an indicator of whether a vessel is directly compressing the facial nerve RED. It is also influenced by a third factor. Based on the current theories, most likely the excitability of the facial nerve nuclei. When the excitability of nuclei decreased after compression, the symptoms of the patient will disappear. This would also explain that the delayed cure occurs in 13 to 50% of patients after HFMD and about 20% on average. Instead of immediate disappearance of the symptoms, these patients experience a period of time just as their AMR did not disappear immediately during surgery. As found in many clinical observations, the AMR did not disappear in some patients right after their decompression, but disappeared when they were explored RED again without any manipulation. Considering that these patients are able to eventually cure after experience a delayed cure, early secondary surgery is not recommended, especially in patients with unstable status based on the quantitative monitoring of AMR. Let's look at some of our quantitative monitoring guided cases and note that there's the letter shows cases that are not part of the mentioned 72 patients. This patient was a 51-year-old female with 3 years of left hemifacial spasm, and there was a video of her preoperative symptoms. Surgery was started with good AMR elicited with a minimal threshold of 10 milliampere, then released the CSF. After decompression, the threshold was raised, 40 milliampere with no response. Corporate vessels at icon. We then raised the threshold to stimulate and focus, found at 80 milliampere AMR was elicited again as intraoperative. Considering the decompression was adequate, and so we not explore the RED again. At the time of the final skin suture, the AMR threshold was 60 milliampere. It was a patency case. 4 days after MVD, the patient's spasms were present, and we rechecked the AMR and found a threshold of 50 milliampere. It was considered to be a fluctuating state of the facial nucleus excitability. Because of the adequate intraoperative decompression, we discharged the patient home for observation. After 2 weeks post-operatively, this patient was cured after experiencing a delayed cure. The patient was followed up at 5 months and 2 years after MVD with no recurrence. Because this lecture, I contacted this patient again 2 days ago for about the 7-year follow-up, and the video chat showed that she was very satisfied with the surgical efficiency and had no other recurrence of the symptoms since 2 weeks after surgery. This patient, another patient, was a 52-year-old female with a left hemifacial spasm for 2 years, and she received a puncture and moxibustion for 2 months. Surgery was started with good AMR elicited with the minimum threshold of 10 milliampere. RED was explored and the culprit vessel was ICA. After adequate decompression, the AMR remained unchanged, and the threshold was also 10 milliampere intraoperatively. Considering the decompression was adequate and we not explore the RED again. And at the end of the surgery, the AMR remained unchanged. 6 days post-MVD, AMR was rechecked. 10 milliampere not elicited. Increased the current to 20 milliampere AMR not negative, but 30 milliampere AMR was elicited. The threshold appeared elevated, and it can be hypothesized that the excitability of the facial nucleus was beginning to diminished. So we began to consider at this time that she might also be a patient with delayed cure. This patient's post-operative symptoms confirmed our judgment, and at 20 days post-operatively, the patient's symptoms persist. At the 2-month follow-up, most of the patient's symptoms had disappeared, with only the twitching of the corners of the eyes involved. Follow-up 3 months after surgery, the patient's symptoms have disappeared. 2 days ago, we contacted the patient again. The patient had no recurrence since the delayed cure, and she is very happy now. Now we get into the part of the clinical significance of AMR. The dynamic quantitative monitoring of AMR threshold can identify the multiple states during HFS MVD. Threshold alterations in AMR intraoperatively may reflect the excitability of facial nucleus, further supporting the theory of the central hypothesis of the HFS. This measure can explain the phenomenon of delayed cure. Patients with AMR instability are likely to have delayed cure. The majority of the patients with delayed cure have unstable AMR. Avoiding the prediction of the surgical efficiency simply by dichotomous view with the AMR. Last but not least, for the surgeon, the unstable state of AMR should be fully understood to guide our surgery. On the one hand, it is necessary to refer to the AMR and consider whether adequate exposure and decompression of the REZ has been performed when the AMR threshold is elevated but not raised above 100 milliampere, especially for young surgeons. On the other hand, we have to avoid over-depend on it, such as stopping complete exploration of the REZ of the facial nerve after the intraoperative AMR threshold is raised for early termination, resulting in the corporate vessel omission, leading to the surgical failure. Or AMR only theory. Whenever AMR is present, repeated multiple excessive exploration of the CPA angle and is performed intending the disappearance of the AMR, which may lead to the incidence of the facial paralysis and hearing loss. Well, in this case, the patient's postoperative relief of spasm is likely to be masked by the paralysis rather than cured. In addition, patients who remain spasm postoperatively and also have a positive AMR are advised to remain under observation, especially whose intraoperative AMR is the instability and belong to the ABCD pattern. Superior technique and experience remain the key to ensure the effectiveness of the MVD. The second part is the BAEP. Hearing loss as one of the most common serious complications after the HFS MVD causes greater suffering to the patients and hinders the use of the MVD surgery to some extent. At present, there is much speculation regarding the cause of the hearing loss. Possible causes include stretching the auditory nerve, ischemia of the internal auditory artery or the ICA, direct damage caused by surgical instruments or nearby coagulation, recompression by the interposed plate, and so on. As for functional surgery, finding method and criteria effectively avoid the hearing loss is worth our effort. Besides BAEP, ecology is the tympanic electrode placed in the external auditory canal and is roughly equivalent to the wave 1 of the BAEP, but with near field potential, high signal-to-noise ratio, and rapid response. However, it only monitors the potential of the cochlea and is more sensitive to cochlear ischemia. We are now also working on BAEP combined with the ecology monitoring. Auditory nerve compound action potentials, CAP. The cotton wick electrode is placed on the surface of the auditory nerve and to record its action potential directly. Near field potential, good signal to noise ratio. But putting the electrode itself may be invasive, and then the operation may move the electrode position difficult to keep in the place on cochlear nerve. It more commonly used in tumor surgery or CP, less used in HFS MVD. BAPS are the most commonly and widely used IOM for MVD targeting auditory pathway integrity and to reduce the hearing complications. BAP, which are mainly stimulated by sound, sensed by cochlear hair cells, travel through the auditory conduction pathway through the auditory nerve, brainstem, and to the cerebral auditory cortex. BAPs are able to monitor the entire auditory pathway compared to the ECOG, and they are also easier to perform and do not require the placement of other electrodes, and also compared to the EIBR or CAP, it does not require placement of the electrodes during MVD and does not interfere with the surgical process. So BAP are the most likely to be used. Let's first look at the current warning criteria for BAP. The typical warning criteria of American Clinical Neurophysiology Society in 2009 is the prolongation of the wave 5 latency by 1 millisecond or a decrease in the wave 5 amplitude by 50%. In China, the recommended warning standard for intraoperative electrophysiology is a 50% decrease in wave 5 amplitude and latency greater than 0.8 millisecond, or any prolongation of the latency or change in amplitude greater than 50% greater than the baseline of the and 1.5 milliseconds need to be investigated for the cause. In clinical practice, it is often found that some patients with transient loss of wave 5 intraoperatively or with wave 5 latency that is already greater than 2 milliseconds may not have significant postoperative hearing loss. In contrast, some patients with little intraoperative BAP change have postoperative hearing problems. False negative and false positive due to this mismatch raises first and foremost the scientific question of what is the predictive value. In addition to this, the non-correspondence also simultaneously raise the questions about the value of monitoring by the operator. The warning criteria of BAP is described by ACNS guidelines as somewhat arbitrary. In other words, that is, our understanding of the warning criteria are not yet comprehensive and perfect, and the currently recommended indicators are the experienced rather than calculated. Next, let's take a look at some of the current research advances on BAP warning criteria. Firstly, the professors Romola of the UPMC and the University of Pittsburgh published an article in Neurology in 2014, in which they retrospectively analyzed the IOM data of 238 patients with hemifacial spasm. The definition of significant change of BAP was the reduction of the amplitude of wave 5 more than 50% and or increase in latency of wave 5 0.5 milliseconds. They found that the sensitivity of the warning criteria was 90% and the specificity was 70%. This warning criteria standard is relatively sensitive, especially the latency of the wave 5. However, the advantage of this is the advantage of this is that the patient is not easy to suffer hearing damage because as long as there is a change in the BAEP, the monitoring will tell the surgeon to stop the operation and wait for the recovery. But it brings the problem that the frequent alarm may affect the surgical process, which prolongs the operation time and may bring more risks. Moreover, we can see that the positive PPV of this indicator, the probability of the patient actually experience high hearing impairment when reporting the warning is only 20%. Meaning that when the monitoring alarm is raised, there is an 80% of probability that there will be no damage. So the criteria with significant change seems too sensitive. The second part shows in the right is the loss of the wave 5, which is categorized into the temporary loss and continuous loss, permanent loss. Which is also flattening of the wave 5 is close to the state of 100% reduction. And we see that the sensitivity decreased to close to 70% and the positive predictive value is also around 50%, which seems to be stronger than a significant change. So they believe that the wave 5 loss is a good specific predictor. But in fact, at the moment of the losing wave 5, we don't know if it will be able to recover at the end of the operation. So if the alarm is raised at this time, will it be too late? This is an article published in Clinical Neurophysiology by Professor Park. They use the high-frequency stimulation and less than average for BAEP monitoring. We see that now the more than 2,000 patients suffering hearing impairment when they had only 1 millisecond prolongation of the wave 5 or only a 50% of reduction in amplitude. And when both latency and amplitude occurred simultaneously, the incidence was only 2 out of 96 cases. In contrast, only about half of those with persistent wave 5 loss also experience a hearing impairment. Each of the warning indicators showed a high level of the false positive. However, it was also conducted that the loss of wave 5 or latency greater than 1 millisecond with a 50% of reduction in wave amplitude was significant. And some studies also point out that the importance of the interpeak latencies and the amplitude of wave 3. So at the very beginning of the doing IOM, I was confused. First, is it too late to lose the wave 5? Our aim is to firstly early warning and secondly prediction. Early warning can guide the surgery, whereas the prediction is just observation. The tool is the latency greater than 1 millisecond and the 50% of reduction in wave amplitude empirical or calculated. What are the predictive value of them? Is there other potential indicator for BAEP that are value, like interpeak latency or amplitude of wave 3? And we measured the latency and the amplitude of the 100 and the 1 and 3 and 5 wave and calculated the IPL in an attempt to find the most relevant indicator of the hearing damage. In this regard, we conduct an observation study in which we finally collect 93 patients. And for better calculation of the warning indicators, we collect the parameters at the moment of maximum change of the BAEP during MVD. Note that we did not include any cases in which we could not determine the absolute value, such as the wave 5 loss, for which we could not determine the absolute value of the latency. And in addition, patients with postoperative conductive deafness was also excluded. Finally, logistic regression calculations of the continuous variables and the 3 category variables of calculation were performed at 10 decibel, 30 decibel, or 50 decibel, according to the patient's postoperative pure PTA decreased value compared to the preoperative value. These are some of our monitoring parameters. Click sound 12.1 Hertz rate and average assault times. In terms of the measuring and calculating method, we measured all absolute value of 1, 3, and 5 wave. And in order to make the values comparable across patients, we also calculated their relative values of change from baseline. This is an illustration of a screenshot of data from a particular patient. The green wave form is the baseline information at the moment of the patient's anesthesia, and the white waveform is the moment of the maximum change in BAP. The yellow color is the measurement of latency, the white color is the measurement and calculation of the wave amplitude, and the blue color is the measurement and the calculation of the interpeak latency. This patient's wave file latency was prolonged by 1.8 millisecond to 33% of 33%, and the wave file amplitude was reduced to 55%, and the postoperative hearing threshold increased by 56 decibel. This is an overview of the calculated values for all patients. The levels at the baseline are within the reference range, and the amplitude range from 0.2 to 0.5 microvolt, and the latency was also normal. This is a logistic regression analysis of all waves of all patients, and it shows that the amplitude and the latency of the wave 5 and the IPLs of the 1 to 5 are statistically significant metrics in all 3 grades of the hearing loss. We also plotted the ROC curves and calculated the area under the curve for these metrics, and it can be seen that the predictive probability of wave 5 amplitude reduction was the greatest for a single metric at all 3 hearing impairment classifications at 80%, 90%, and 98% probability, respectively. Secondly, at 30 decibel and 50 decibel of hearing impairment, the predictive probability of interpeak latency for the wave 1 to 5 was superior to the latency prolongation of the wave 5 alone. And this is the table shows the optimal cutoff value calculated on the basis of the ROC. Therefore, obtained the predictive value of each indicator at 3 hearing loss level. In the case of the severe hearing impairment, such as 50 decibel, the cutoff value of amplitude of wave 5 was 55%, and the 0.6 milliseconds prolongation of the interpeak latency of 1 to 5. Also, we can see that in our set of data, the value of wave 5 latency is lower than the interpeak latency of 1 to 5. Similar results can be seen at the 2 other levels of the hearing impairment. Summary of this part of highlights. One is to recommend that the scale warning strategy, the wave 5 amplitude reduction has the highest predictive value, 34 for 10 decibel, 46 for 30 decibel, and 55% for 50 decibel, followed by the IPL 1 to 5 within 0.6 millisecond. Last is the latency of wave 5. Secondly, in terms of the predictive value, both the operator and the electrophysiologist need to be constantly aware that the positive predictive value is only about 50% with the recommended matrix, and the negative predictive value is high. In other words, the warning is not present. The warning is not present, and there is a high probability that the damage will not occur. We need to recognize that the objective limitations of the BAEP monitoring do not underestimate its value and do not rely exclusively on BAEP's indicator for decision making. Our study also have some limitations, and correcting the predictive model after expanding the sample size will better clarify the predictive value. Finally, let's summarize today's contact with the case study. This is an example of the application of both AMR and BEP in HFS MVD surgery. This patient was a 45-year-old female with right hemifacial spasm for 4 years. At the beginning of the procedure, we can see that the baseline is well. During the incision of the dura and the release of the CSF, the BAEP waveform does not change much, and then we decompression. At the end of the decompression procedure, the AMR threshold raised to 60 milliampere, and we could see a large drop in the wave file amplitude. Although at the moment, the wave file latency did not change dramatically. We immediately stopped the further surgical operations and the infusion with warm saline water into the surgical field, and waited for BAEP recovery while we see the AMR wave disappearing in this time. A few minutes later, we saw some recovery of the wave file amplitude, and although the AMR was still positive, we did not continue to explore the REZ because we were sure that the decompression was adequate. After closure, the BAEP waveform was essentially normalized, but the AMR was still present with a threshold of 20 milliampere. This patient has an AMR change pattern of C, unstable state, which may be delayed cure. And when the BAEP waveform dropped, we stopped the operation in time, and eventually the BAEP was recovered. At the end of the procedure, I saw a transient 4 to 5 subtle twitch in the patient's face, but they were not captured during the video, and were not noticed by the patient herself. At 5 days post-operatively, the patient still reported there is no spasm, while the recheck AMR was negative in 10, 20, and 30 milliampere. I followed up with her in 2018 and 2 days ago, and she recovered with no spasm or nor hearing loss. Take-home messages: IOM is very helpful in HF MVD. As for AMR, avoid the prediction of MVD efficiency simply by positive or negative view. Dynamic quantitative monitoring of AMR threshold may help to better understand the clinical outcome of the HF MVD. Do not do early secondary surgery due to the delayed cure. As for BEP recommendation, is that step warning strategy. Combined monitoring of the indicator is best, but for a single indicator, a decrease in wave 5 amplitude has the highest predictive value, followed by a prolongation of the IPL 1 to 5 wave, then a prolongation of the latency of the wave 5. Finally, throughout understanding of the concept of decompression and electrophysiology, continuous accumulation of practical experience, careful and patient operating habits is the key to success, and do not over depend on IOM. Finally, this is a picture of our hospital. Our China-Japan Friendship Hospital is located in Beijing, capital of China, and we welcome you to come and visit us. Our hospital has been dedicated to microvascular decompression surgery since 1984, and welcome you to contact us. Thank you for listening, and best wishes for all of you.
Thank you so much. So shall I invite any questions from the floor?
Prof. Atia, would you like to comment something?
I think it's really very nice presentation, and you took it to another level of kind of prediction of the successful surgery, yes or no, very academic. I think the take-home message that you taught us now, that you do not give up unless it passed 1 year to say if this operation is a failure or not. But it's really nice to see that you can predict during the surgery and after the surgery the results of the surgery. It's very nice.
Thank you. Thank you for comments.
Professor Sugawara is still with us. Prof. Sugawara, are you here?
Thank you, Professor John, for your very nice presentation. I would like to ask about, since I can see at the beginning of your slide, so you mainly focus on AMR in this presentation. Because in my unit, so we usually monitor the lateral spread. So what is your opinion in using the lateral spread during the hemifacial spasm? So this is my first question. The second question is, I think that during the surgery, so sometimes the interpretation of the amplitude of the facade, either in AMR or lateral spread, is quite difficult to interpret. For example, let's say, so the facade has significantly increased. So what does it mean by significant increase? So it's different in different patients. I can see that you're in your study, you use the pattern to predict the success of the operation. So how about for the lateral spread? So is there any experience in using the lateral spread, and any tips for using it during surgery? Thank you so much.
Okay. Thank you for comments and question. The LSR and AMR, in my opinion, is the same thing, but the hypothesis behind it is very different. Because the AMR just describes the phenomenon that the response is not found in the normal patient, but the lateral spread response mainly focused on the mainly focused on the outside of the brain stem. So the hypothesis behind it is very different. As for the clinical significance, I think the AMR is more important for younger surgeons. And when they perform the MVD, when they hear that the AMR is dismissed, the younger surgeon will confident to do the surgery. But for the skilled surgeon, they have a lot of experience on how to find the nerve, how to explore the REZ, and how to decompress use with skilled technique. So for the skilled surgeon, the IOM for the limited. As for the second question, the threshold of the AMR is very important. So how can we better understand it, and how we can interpret it during surgery? We mainly focus on the stable stable. When the AMR is change is stable, they might have a similar outcome. But when when the changes of the AMR was unstable, they mightly belong to the delayed cure or so-called delayed resolution. It's a very common phenomenon in the clinic, and we recommended we do not perform the short-term surgery after first MVD because many people may suffer the delayed cure, and when you do the surgery in short term, the patient may suffer twice risks and have a more higher complication rate.
I see. Also, I want to hear your comment about during the surgery. I can see that you correlate the surgery to different phases with your AMR pattern. So sometimes our experience that sometimes for example, in the hemifacial spasm, so the lateral spread will disappear after the alveoli dissection. So if you clear the alveoli that is attached to the vessel or surrounding the root axis zone, there will be improvement as evident with the lateral spread. I wonder if this phenomenon can be observed with your AMR pattern.
So what's the question? Sorry.
So in your AMR pattern, so for example, if after the alveoli dissection, just before you free the vascular,
it belongs to
pattern
before the it belongs to pattern A.
Type D, I see.
Yeah. And in this pattern, we assume that the excitability of the facial nucleus is very high, and only little decompressions can make the outcome well.
I see. Thank you, and congratulate on your results. And it's a very nice study, and happy to learn that from you. Thank you so much.
Thank you for comments. Thank you.
Thank you very much, Ben. In that case, I think we can conclude this session. Dr. Ben, would you like to conclude this?
Yes, and thank you, Roger. So first of all, I'd like to thank both the speaker, Professor Aitia, and also Professor Zhang for giving the speech. Both of the lectures are very informative and very important to a young neurosurgeon. And I will also thank you, Professor Takashi, for chairing the first session. So on behalf of the Education Committee of ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Dr. Moshi Aitia, and also Professor Zhang Yulin, as well as the chair and Professor Takashi for the time and the support for the ACNS webinars. A special thanks to Professor Xu Bin for broadcasting this webinar on WeChat channel. And today we have more than 2,000 people watching live on the WeChat channel. And special thanks to my co-hosts today, Dr. Roger, and thank you so much for sharing the session together. So until we meet all online tomorrow is a bye-bye from all of us, and thank you so much for joining.